Good morning. We will discuss upper respiratory disorders in primary care. Some upper respiratory disorders that we find in primary care include influenza, cough, bronchitis, bronchiolitis, and obstructive sleep apnea. So some diagnostic considerations in primary care consider the problems of the head, ears, nose, and throat. Remember that your initial viral infection may progress to a secondary infection of the upper or lower respiratory tract. Consider some concepts of secondary infections. Think about the fact that you are adults and children with constitutional conditions such as bronchitis, allergies, asthma patients, cystic fibrosis patients, you're diabetics, that their conditions may develop into a secondary infection. Also consider the concept of superimposed bacterial pneumonia. So if a patient isn't getting better after treatment, you want to consider bacterial pneumonia. Also consider other circumstances in making your diagnosis. Think about your smokers, your diabetics, and also your asthma patients. And you want to be able to treat these patients with this condition so they don't end up in the emergency room. These are common upper respiratory infection terms that we use. So rhinitis is an inflammation of the nasal mucosa. Rhinosinusitis or sinusitis would be your inflammation of the nares or the paranasal sinuses. And these include your frontal sinus, your ethmoid sinus, your maxillary sinus, and sphenoid sinus. So your nasopharyngitis would be your inflammation of the nares, your pharynx, the hypopharynx, uvula, and tonsils. And pharyngitis will be your inflammation of the pharynx, the hypopharynx, the uvula, and your tonsils. Epiglottitis would be an inflammation of the superior portion of the larynx and the supraglottic area. Laryngitis is an inflammation of the larynx. Your laryngotracheitis would be your inflammation of the larynx, the trachea, and the subglottic area. And tracheitis would be your inflammation of the trachea and subglottic area. So the first question you want to ask yourself is this infection viral or bacterial? Patient history is not a reliable differentiator, so you'll have patients that come in and they tell you that they need antibiotics, but what you assess tells you that this is a viral infection and antibiotics wouldn't really do any good. So as for symptoms, how long has the symptoms been going on? Is it more than 10 days? Is the symptoms progressively getting worse after the first 5 to 7 days? Consider that for strep pharyngitis, the patient might have a history of rheumatic fever, especially carditis and valvular disease, or they may have a household contact, so a sick contact with history of rheumatic fever that increases a person's risk. So always remember that. So some symptoms that we find with strep pharyngitis will be fever greater than 101, sudden onset, no other symptoms, so there's no cough, there's no rhinorrhea, no conjunctivitis, but the patient may have a rash, especially in children. Also consider the secretions. They could be both thick or yellow in viral or bacterial infections. So we have patients that come in and tell you, oh, my sputum is yellow and the secretions, my nasal secretions are typically yellow in color, so that means that it's bacterial. But always remember that both viral or bacterial infections could have secretions that are thick or yellow. We'll talk a little bit about influenza. So this is fairly common in your primary care setting. The classic flu, we have two types, influenza type A and influenza type B. So I wanted to talk about coryza, and coryza describes your head cold, and that is a typical symptom that a patient would have when they come in. So with influenza A and B viruses, the incubation period is 1 to 3 days, but the virus will shed in 7 days. The clinical aspect of the flu, remember that everyone with a cold thinks they have a flu. So how do you differentiate? So in the primary care setting, we'll talk a little bit about the testing that can be performed. What do you tell the person with a common cold who thinks they have the flu? So again, you as a clinician would have to make that diagnosis and not the patient. Keep that in mind. So with influenza, the clinical manifestations, the symptoms that the patient presents with, it could be an abrupt onset. So the patient might tell you that they were at work and they suddenly felt feverish. They may have some chills, shakes, and the fever could be between 100 to 104, which is, a high fever. They may have severe sore throats that last up to 3 to 5 days. With influenza, there's a lot of myalgia, so body ache. The patient would typically tell you that they have a lot of fatigue and body ache going on. They may have some headaches. This is pretty common. And they're usually severe in influenza. The patient might have some ocular symptoms like photophobia. They may have some burning sensation and pain on movement. So just, sitting to standing, they may have, a headache or pain in the eyes. Rhinitis is another clinical manifestation. The patient might be weak and they have severe fatigue. They also may present with some cough and upper respiratory infections, and this usually will progress as the infection evolves. The patient might have a dry cough, or they may have some chest tightness with the cough and shortness of breath. Also keep in mind that in children, diarrhea might be a symptom that you would see with the flu. Keep in mind that a patient that comes in may have all or some of the physical findings listed here. So they may have a fever between 100 to 104. In your elderly patients, the fever might not be as severe as in your young adults. So an elderly patient might come in and they really do not have a fever, or maybe they just have a low-grade fever of 99.8 or 99.4. So keep that in mind. The patient may present with tachycardia, so elevated heart rate from hypoxia or fever or both. The patient might have pharyngitis, minimal to more severe inflammation, red and watery eyes, nasal drainage is generally absent with the flu. Remember that. The patient, other physical findings, poor skin turgor. The patient might be a little dehydrated. There might be a dry cough, and on auscultation, you'll find that the lungs are clear, or they might have a rhonchi. There may be some lung infiltrates, and if you hear any crackles, you definitely want to get some imaging studies, so chest x-ray would be where to start. In the elderly or your high-risk patients with pulmonary symptoms, you definitely want to order a chest x-ray to exclude pneumonia. And if a patient comes back with focal infiltrates that indicate superimposed bacterial pneumonia, then you want to treat this patient accordingly. Neuro findings may be present in severe cases, so a patient might come in with some acute encephalopathy, especially with flu A, altered mental status, coma, seizures, and ataxia, and you know that this kind of patients do not belong in your exam room. They should be in the emergency department. So keep in mind that Typically, laboratory tests are not ordered for the flu, but if you decide that you want to order some blood work for this patient, you can go ahead and order your CBC count and electrolytes. They're real non-specific, but they may be helpful in certain patients. You may find that the patient has some leukopenia and lymphopenia, and these are typical findings. The patient may also present with some thrombocytopenia, but the gold standard for diagnosing your flu A and B would be your viral culture. And the sample is taken in the nasopharynx, or in some clinics, it could be from the throat. But what I find in primary care would be typically from the nasopharynx. And the test will be run. It typically will take 15 minutes. Again, it depends on where you work. So with rapid tests, you can get the results of your flu test in 15 to 20 minutes. The only disadvantage of your rapid tests for flu A and B would be cost and potential false negative results. And just keep in mind that the sensitivity is between 60 to 70% for those tests. So these are some treatment options and chemoprophylaxis that we use in primary care. So of course, prevention is where you want to start from. So immunizing your elderly patients, your pediatric patients, your healthcare workers, and your immunocompromised patients with the flu shot earlier on in the flu season. So amantadine and rimantadine are some chemoprophylaxis that we use, 100 milligram twice a day for 7 days, or 200 milligram in divided doses for 7 days. Relenza, we can do 10 milligram inhaled twice a day for 5 days. And really, I do not use this in primary care. What we use mostly will be Tamiflu, 75 milligram twice a day for 5 days. And remember to always tell your patients that Tamiflu isn't a cure for the flu, but it helps to decrease the symptoms and hopefully, get the patient to feeling better soon. So let's shift gears a bit and talk about cough. So cough accounts for 300 million outpatient visits annually. 10 to 20% of your adult patients will present with a cough in the primary care setting. So some cough you can categorize as normal because the patient is just trying to clear their airway, or pathological because there's an illness related to this cough. For chronic cough, the duration is greater than 8 weeks in adults and greater than 4 weeks in children. So again, we talked about chronic cough lasting for more than 3 to 4 weeks. And these are some differentials that you should keep in mind. So the patient may have a postnasal drip. They may have some reflux, so GERD, or reactive airways such as asthma. Some more differentials for a cough. Postnasal drip, we talked about that. A patient that maybe has had some bronchitis and post-infection, always remember to tell your patients that the cough is the last thing to go with bronchitis. Remember your asthma patients, GERD, ACE inhibitors. So again, that's a side effect of taking your ACE inhibitors in patients that will present with a cough shortly after you prescribe ACE inhibitors. And as soon as you deprescribe your ACE, the cough goes away. And also patients that have exposures to environmental factors such as smoke, pollutants, or patients that work in chemical plants. Think about some differential diagnosis of chronic cough. These are less common in primary care. So your post-viral cough, bronchitis. Again, remember to tell your patients that the cough is the last to go. It might last up to 2 to 3 weeks before it finally goes away. Pneumonia, bronchiectasis, lung cancer, CHF, so heart failure, congestive heart failure, TB, ACE inhibitors, or psychogenic. And in children, bacterial bronchitis will be some differential diagnosis, postnasal drip, asthma, or GERD. So keep that in mind. Again, as good clinicians, you want to start off by taking a good history, because once you get a good history, you can make a good diagnosis. So you want to ask the patient, how long has this cough been going on? When does it occur? So is it worse at night or is it worse during the day? What stimulates the cough? So is there any setting position, maybe after eating and laying back? If a patient tells you that they're coughing, then you want to consider GERD as an offending factor. Is there anything that makes it worse? So how long has this been going on in terms of frequency? How severe is this cough? What is the character of a cough? Is it productive or is it just a dry cough? If it is productive, what is the amount of phlegm that the patient is bringing up? So is it a scant, or is it moderate, or is it a whole lot of phlegm? Find out if a patient is a smoker. Has a patient had a recent upper respiratory infection or exposed to it? Does a patient have any sensation of something dripping down the throat? Then this will give you a clue for a postnasal drip. Does a patient have any allergies, any purulent nasal discharge, or facial pain? So again, with history taking, ask the patient if they've had any wheezing related with a cough, any shortness of breath. Does this cough interfere with exercise? So do they have any shortness of breath when they're exercising, or do they have any cough? Is there any heartburn going on? Do they have a sour taste in the back of their throat? Hemoptysis, so coughing up blood. Again, we find coughing up blood with bronchitis, but of course you definitely want to explore if a patient tells you that this has been persistent for a couple of weeks, you'll consider TB or even lung cancer with hemoptysis. Some medications that patient would be taking, again, like I said, your ACE inhibitors will be culpable medications for this. Some weight loss or night sweats, and of course consider TB or any recent foreign travels. On your physical exam, again, you want to take a good look at the patient's nasopharynx. So do they have any postnasal drip and any mucoid secretion in the oropharynx, any cobblestoning of the posterior pharynx? Is there any edema going on? Any pale nasal mucosa? Any tenderness of the sinuses? This will give you a clue. Listen to their chest. Is there any expiratory or local wheeze going on? Do they have any cerumen impaction or hair in the tympanic membrane? Do they have any enlarged neck nodes or masses? Any crackles on auscultation? Listen for any S3 or JVD. Also, you can look at their sputum. So if a patient is actually coughing up phlegm, you can ask them to take a look at it. Does a patient have any clubbing? And this is indicative for heart failure. Okay, so we'll talk about some diagnostic protocols. The first thing you want to do is to eliminate the irritant that could be causing the cough. So again, we talked about medications that could result in a cough, like ACE inhibitors. You want to be able to think about the empirical treatment, and we'll talk about those in a little bit. Spirometry testing, especially if you're suspecting asthma or COPD. Again, pulmonary function tests to check for the lung capacity of those patients. The methacholine inhalation challenge is another test that you can use to make a good diagnosis. The chest x-ray, if you're suspecting pneumonia, you can send this patient off to get some imaging done. Bronchoscopy is another diagnostic protocol that we want to keep in mind. So if a patient has night sweats and maybe they've had some foreign travels and they have a cough with hemoptysis, you definitely want to consider bronchoscopy. So you send this patient out to a pulmonologist. PPD, so if you're again suspecting TB, you can order some blood work, so CBC blood culture, and with bacterial infections, we find that the white blood count is elevated. You can decide to order a sinus film, so sinus X-ray or CT. And of course, if you're suspecting that the patient might have a mass or cancer of lungs, you want to order a CT scan. All right, we'll talk a little bit about the empirical treatment. So for your postnasal drip, you want to prescribe some intranasal steroids, some antihistamine, some decongestants. For GERD, you will consider your proton pump inhibitors, so your PPIs like Nexium, Protonix, really to suppress the acid in your GERD patients. And of course, lifestyle changes, so encourage the patient to lose weight, to avoid alcohol, spicy foods, and also to wait 2 to 3 hours after a meal before going to bed. With bronchitis, we use a lot of inhaled corticosteroids. ACE inhibitor you want to discontinue and bring this patient in and monitor and make sure that that is what is causing the cough. So for suspicious X-ray, so you've gotten an X-ray and it shows you that maybe there's a mass, you may want to consider bronchoscopy. So for unexplained cough, you just want to make sure that you're prescribing some antitussive medications. So think about your guaifenesin, your robitussin, your Mucinex. Okay, we're going to go over the algorithm for children, and this is your 2017 algorithm by the American College of Chest Physicians. So what they recommend is that for your children they're coming with dry cough, you want to prescribe some inhaled corticosteroids. Okay, if the patient comes in and their cough is productive, consider giving some antibiotics. So we start with augmentin, that is amoxicillin with clovelinate, for again dosing according to weight. And if no improvement, then you want to go ahead and perform a CT scan. I also wanted to make sure that I bring to your attention that now there is a high quality evidence that in children less than 14 with chronic cough, so if you've had a cough that is greater than 4 weeks in duration and you have gone through the algorithm, consider that the patient may have asthma, especially when you have performed a chest x-ray and nothing is wrong on the chest x-ray. You want to consider sending the patient out to perform a spirometry testing, of course with beta agonists before and after should be undertaken. So the algorithm tells us how to evaluate a patient that comes in with a wet and dry cough. So with a dry cough, you want to perform a trial therapy with your inhaled corticosteroids. And you want to tell the patient to come back in if they don't feel better. You want to review in 2 to 3 weeks to find out if the cough is resolving or not. If a cough isn't resolving, then you want to reevaluate by ordering a chest x-ray and spirometry testing. You can also consider getting a CT scan and think about some abnormal lesions that could occur in this patient. So with a spirometry testing, you can get a diagnosis of asthma. And then also for a wet cough, you want to be able to start this patient on augmentin for 10 days, so twice a day for 10 days. and have a patient come back in 2 to 3 weeks if they don't feel better. And if a cough hasn't resolved, you want to go ahead and order a chest x-ray or spirometry testing. And again, think about the fact that if the patient still has, you don't see any valuable information, or you don't view any valuable information on the chest x-ray, you may want to order a CT scan to further explore for any masses that could occur. And of course, you have the opportunity to send this patient to a pulmonologist for further assessment. Acute bronchitis is an inflammation of the trachea, the bronchi, and bronchioles. Patients would typically present with a cough with phlegm, so it could be a productive cough. And there could be retrosternal pain with deep breathing, so the patient may tell you that they have some chest tightness when they cough. The causative agents for acute bronchitis include rhinovirus, Bordetella pertussis, adenovirus, and the flu virus, amongst others. Always remember that acute bronchitis is rarely bacterial. It typically occurs as a complication of a viral upper respiratory infection. It's self-limiting between 10 to 14 days. And remind your patients that the cough follows shortly after a URI and may last up to 3 weeks. It's self-limiting, remember? And we find that it occurs more in females than in males, and is most common in children that are less than 2 years of age, and pediatric patients 9 to 15 years of age. The clinical presentation of acute bronchitis include coryza. We had talked about coryza being upper respiratory infection related to sneezing and runny nose and cold-like symptoms. Malaise, so they have a lot of fatigue going on. They may have chills, slight fever, sore throat. They may have some back or muscle ache. So the clinical presentation with a cough could be a dry cough. It could be dry, raspy, harsh cough, or it could be productive. So the patient might tell you that they have a lot of phlegm. In patients, some of the patients would have hemoptysis, so cough with a blood-tinged sputum, and some shortness of breath could also be part of a clinical presentation for acute bronchitis, as well as wheezing. So keep that in mind. So I talked a little bit about the etiology. So with viral bronchitis, you can see the causative organisms. RSV is one of them. Adenovirus, influenza, parainfluenza, rhinovirus, the Coxsackie virus, and HSV. Sometimes air pollutants could be a part of the causative agent, so you want to keep that in mind. For bacterial bronchitis, you have S. pneumonia, M. catarrhalis, H. influenza, chlamydia pneumonia, Mycoplasma species, and fungal infections. So sometimes you may have to consider that the patient may have seasonal allergies or just in general complications of an allergy. Also keep in mind that with a cough, the patient may have reflux symptoms, and that could really be the reason why they have a cough and not because of any virus. So keep that in mind. These are some diagnostic studies that may be performed in patients with acute bronchitis. You may want to perform a serum C-reactive protein screening, a respiratory culture, serum cold agglutinin testing, a blood culture, or a sputum culture. Remember that the patient may have a concomitant flu virus infection, so a nasopharyngeal swab for chlamydia, antigens of the flu may be performed. If the cough is prolonged, you may consider performing a pulmonary function test or ordering a pulmonary function test. And of course, a chest x-ray may be required. So let's talk about the management of acute bronchitis. So remember that I mentioned that bronchitis occurs in patients and the causative agents will typically be viral in 90% of patients. So some patient education could include telling your patients to quit smoking, increasing fluids, avoid caffeine and alcohol. They could use some hot spicy foods, that could help. They could use some vaporizer and remind them that the cough may last up to 3 weeks and it lingers and is the last to go. They could use some guaifenesin, so you can order some guaifenesin. And they could use that every 4 to 6 hours, really just to decrease the cough reflex. And Atrovent inhalation solution can also be used. So with bronchiolitis, it is an acute inflammatory injury of the bronchioles, and it typically occurs with a viral infection. So we find that bronchiolitis occurs in persons of any age, but is more severe in young infants. So some signs and symptoms of bronchiolitis in young infants that we've seen is that the patient might be more fussy. They may have a low-grade fever. They would have increased coryza and congestion. And the patient may be tachypneic. They may have some tachycardia and some wheezing may be present. So there is really no diagnostic criteria for bronchiolitis except physical exam. So the clinical presentation would warrant you as a provider to suspect bronchiolitis, especially with the young infants that present with the symptoms that I talked about. Chest x-ray is typically not performed in these patients, but in management of bronchiolitis, oxygen improves the condition of young children. Therefore, therapy is directed towards symptomatic relief, maintenance of hydration, and oxygenation. So patients will typically be hospitalized for a couple of days, really to provide supportive care. So nebulized ribavirin has been found to be helpful in these patients. Also albuterol, so alpha or beta agonists can be considered. Epinephrine can also be considered. But remember that prevention is key in bronchiolitis. So providing monoclonal antibody or RSV immunoglobulin may be helpful in preventing bronchiolitis. Some complications that we found, bronchopneumonia would be one of them, bronchiectasis, and acute respiratory failure could be complications of bronchiolitis. So you want to tell the parents of young infants and your pediatric patients about immunization. So your Tdap, your flu vaccines, those are real important to prevent bronchiolitis and in general upper respiratory infections. Avoid smoking, especially in households where the parents smoke. Air pollutants like solvents or cleaners or smoke should be avoided. And children may attend school or daycare, or parents can attend work unless if they have a fever. So if they're febrile, they cannot attend school or daycare. Sleep apnea is a common disorder that causes your breathing to stop or to get very shallow. The breathing pauses can last from a few seconds to minutes, and they may occur 30 times or more an hour. With obstructive sleep apnea, there is an upper airway collapse during sleep. So it causes your airway to collapse or become blocked during sleep. And we find that this is more prevalent in men than in women. And of course, with children who have enlarged tonsils or adenoids, they may also have sleep apnea. So sleep apnea is associated with hypertension, pulmonary hypertension, coronary artery disease, poor concentration, some erectile dysfunction, obesity, depression, or patients who have had a stroke. So the history, you want to obtain a good history of a patient that comes in and they tell you that they have loud snoring, that they find that they're tired when they wake up in the morning, they have daytime fatigue, they have morning headaches, so they wake up with a headache. Patients who have restless sleep habits and frequent cat naps, so patients that fall asleep at work or in school, and you definitely want to get a good history for you to be able to make a good. So in physical exam, we find that the patient has excess weight. So obesity increases the risk of sleep apnea, especially with fat deposits around the upper airway that can obstruct breathing. Patients with sleep apnea have thicker necks, and this may narrow the airways. They may have some tonsillar hypertrophy, excess soft palate tissue, large tongue, some nasal obstruction, and the confirmation is sending a patient out to obtain a sleep study. And that's how you get a definitive diagnosis. So treatment options are of two types. So we have a non-surgical treatment option, which includes weight loss, so encouraging patients to lose weight, and CPAP, which is continuous positive airway pressure. We can use this with, it's an assisted nighttime ventilation. And the CPAP machine, what it really does is to provide air pressure that is somewhat greater than that of the surrounding air, which is just enough to keep your airway, upper airway passages open and prevent apnea and snoring. Surgery could be performed on these patients, so a tracheotomy can be performed, and the uvulo-palatopharyngoplasty, which is tissue removal. So the surgeon goes in and removes tissue from the rear end of the mouth and the top of the throat, and the tonsils and the adenoids could also be removed as well.